You took your pill this morning, maybe with coffee, maybe with breakfast, maybe right after you brushed your teeth. You have been doing it that way for years. Your numbers look fine at the doctor's office. You feel okay. So everything must be working. It is not. There is a specific window inside every 24-hour period when your cardiovascular system is under maximum stress. Your blood pressure spikes, your arteries strain, your heart works harder than at any other moment of the day. And for most people on blood pressure medication, that is the exact window when their medication is at its weakest point, quietly wearing off while the danger quietly builds. This is not a rare problem. This is not an edge case. This is happening right now to millions of people who are doing everything they were told to do and still sitting exposed to the highest risk cardiovascular window of the day without knowing it. There are 5 timing mistakes that people on blood pressure medication make every single day. Most of them were never warned about any of these. Some of these mistakes look harmless. One of them looks like a good habit. And the one we are going to cover last, number 1, is the mistake so deeply embedded in how blood pressure medication has been prescribed for decades that most doctors have never once questioned it. That one alone could change everything about how you manage your heart health from this point forward. Stay with me, because by the end of this, you are going to know things about your own medication that most people spend years on a prescription never learning. Before we go any further, here is something worth understanding about your body and blood pressure after the age of 60. Your cardiovascular system does not operate on a flat line throughout the day. It runs on a precise biological clock. Your circadian rhythm and blood pressure is one of the most tightly controlled variables that clock governs. In a healthy adult, blood pressure naturally dips between 10 and 20% during sleep. The heart gets a rest, the arteries decompress, the system recovers. Then in the early morning hours, typically somewhere between 4 and 10 in the morning, blood pressure surges sharply upward as cortisol levels rise. The sympathetic nervous system activates and your body shifts into its daytime operational mode. This is called the morning surge. Here is why that matters so much. Research published in the journal Hypertension found that this morning surge is responsible for 49% of all strokes and 40% of all heart attacks that occur within any given 24-hour period. Nearly half of all strokes happen during that one window, and the reason is not mysterious. After 60, arterial walls lose elasticity, up to 30% of their flexibility over time. Stiffer arteries have far less room to absorb a sudden spike in pressure. That morning surge hits harder, resists longer, and does more damage than it would in a younger cardiovascular system. Your medication needs to be fully active during that window. Whether it is or not depends entirely on when you take it. And that is exactly what we are going to break down right now. We are starting with number 5, and this one hides inside something that feels like a perfectly healthy morning habit. If you are taking a beta blocker, medications that include metoprolol, atenolol, or carvedilol, and you are drinking coffee within 30 minutes of taking your pill, you are creating a direct conflict inside your own cardiovascular system. Not a theoretical one, a measurable, documented one. Here is what is actually happening. Think of your sympathetic nervous system as a gas pedal. Caffeine presses that pedal hard. It raises your heart rate, triggers adrenaline release, and produces a temporary but real spike in blood pressure. Beta blockers work by doing the opposite, blocking that gas pedal, slowing the heart rate down, and reducing the force of each contraction. When you take your beta blocker and drink your coffee within the same 30-minute window, you are simultaneously pressing the accelerator and the brake inside your cardiovascular system. For most people, the medication eventually wins that competition. But for people with any history of arrhythmia or irregular heartbeat, the friction between caffeine's stimulating effect and the medication's suppressive effect during caffeine's peak absorption window, roughly 30 to 60 minutes after you drink it, can trigger symptomatic palpitations, a fluttering sensation in the chest, a racing feeling, an irregular beat that feels alarming even when it is not causing a cardiac event. A research program tracking over 3,000 patients on beta blockers across 4 years found that those who consumed more than 2 cups of coffee within 60 minutes of taking their dose had a 22% higher incidence of symptomatic palpitations compared to those who spaced their coffee by at least 45 minutes. That is not a small difference for something this easy to fix. The solution is simple. If you are on any beta blocker, wait a minimum of 45 minutes between taking your medication and drinking your first cup of coffee. Let the medication absorb first. Decaffeinated coffee carries no significant interaction, so that is always an option if the wait feels difficult. And when you take your pill, drink a full glass of water. Hydration improves consistent medication absorption and reduces the concentration spikes that make interactions worse. Now we move to number 4, and this one involves something most people have already heard about, but heard about in a way that seriously understates how long the danger actually lasts. Grapefruit and grapefruit juice contain compounds called furanocoumarins, and the way these compounds interact with certain blood pressure medications is not what most people imagine. It is not a direct chemical reaction. It is far more disruptive than that. Your digestive system has an enzyme called CYP3A4. Think of it as a security checkpoint whose entire job is to regulate how much of a drug actually makes it into your bloodstream. It processes medications and controls the concentration reaching your system. Furanocoumarins do not just reduce that enzyme's effectiveness, they essentially disable it. And they disable it for up to 72 hours after you consume grapefruit. That number is the one most people miss. Not 72 minutes, 72 hours, 3 full days. When CYP3A4 is blocked, calcium channel blockers, medications like felodipine, nifedipine, and amlodipine bypass their normal processing and flood your bloodstream at concentrations 2, 3, sometimes even 5 times higher than the intended dose. The result is an exaggerated, uncontrolled drop in blood pressure, dizziness, lightheadedness, and in older adults who already have reduced vascular tone, dangerously sudden fainting episodes. Research tracking nearly 3,000 patients over 3 years found that those who consumed grapefruit products within 72 hours of dosing had a 31% higher rate of hypotensive episodes, dangerously low blood pressure events, compared to those who avoided grapefruit entirely. This does not mean having a glass of grapefruit juice on Monday and then being safe by Tuesday afternoon. You remain in the danger window through Wednesday night and into Thursday. If you are on any calcium channel blocker, the only safe answer is to eliminate grapefruit products entirely. Orange juice, apple juice, and water carry no significant interaction, and if you are unsure whether your specific medication is affected, ask your pharmacist directly. Not whether calcium channel blockers in general interact with grapefruit, but whether your exact medication does. One additional note worth knowing: magnesium-rich foods such as spinach, pumpkin seeds, and almonds may help support healthy vascular tone alongside calcium channel blocker therapy without interacting with the drug. If you are on long-term calcium channel blocker treatment, it is worth asking your doctor about checking your magnesium levels at your next appointment. On to number 3. And I want you to pay close attention here because this mistake does not look dangerous. It looks like an inconvenience. It looks like poor sleep. It looks like an older person's body just not cooperating the way it used to. It is none of those things. It is one of the most preventable causes of catastrophic physical injury in adults over 70. Diuretics, commonly called water pills, are among the most frequently prescribed components of blood pressure treatment. Medications like hydrochlorothiazide, furosemide, and chlorthalidone work by signaling your kidneys to excrete more fluid, which reduces blood volume and lowers blood pressure. Less fluid, less pressure on the arterial walls. The mechanism is straightforward. The timing problem is this: many people, often because they forgot their morning dose or because they were simply never given specific timing instructions, take their diuretic in the late afternoon or evening. That drug then reaches its peak effect in the middle of the night. The kidneys begin excreting fluid. The bladder fills. A person wakes up at 1 or 2 or 3 in the morning, gets out of bed in the dark, and stands up. When you stand up suddenly after sleeping, blood pressure shifts. In a younger person with responsive vasculature, the body adjusts automatically and quickly. In an adult over 70 where that adjustment mechanism is slower and where the diuretic has already reduced blood volume, blood pressure can drop sharply the moment they stand. This is called orthostatic hypotension, and it affects nearly 30% of adults over the age of 70. What happens next is where this becomes a life or death issue. The National Institute on Aging has identified nighttime falls in adults over 70 as the leading cause of hip fractures. And hip fractures, listen to this number carefully, carry a 1-year mortality rate of between 20 and 30% in patients over 70. That means 1 in every 4 to 5 people who fracture a hip after age 70 will not be alive 1 year later. That is the downstream consequence of taking a water pill at 6 in the evening instead of 8 in the morning. Research from a Harvard-affiliated institution examining nearly 15,000 patients receiving diuretic therapy found that late afternoon dosers, those taking their water pill after 2 in the afternoon, had a 44% higher rate of nighttime falls requiring emergency medical care compared to morning dosers. 44%. For a timing decision that takes no effort whatsoever to change. The rule here is absolute. If you are taking a diuretic, take it before 10 in the morning. If you are on a twice-daily diuretic, the second dose should be taken no later than 2 in the afternoon. That timing keeps peak diuretic effect safely within daylight hours when you are upright, alert, and able to respond to how your body feels. Because diuretics can deplete potassium over time, pair your morning dose with a potassium-rich food, a banana, plain yogurt, or a small handful of sunflower seeds. Supporting your potassium levels naturally helps maintain a healthy heart rhythm, and it is a simple daily habit that costs almost nothing. Now we are at number 2, and this is one where the danger is hidden inside something that feels completely logical in the moment it happens. You forget your morning dose. You remember at 2 in the afternoon or at dinner or right before bed, and your first instinct is entirely reasonable. Take 2 tonight to make up for it. After all, you still need the medication. You still need the coverage. Doubling up seems like a way to stay on track. For some medications, this is a low-risk error. For others, it can trigger a cardiovascular emergency. Here is what happens inside your body when you double a dose of a calcium channel blocker or a long-acting ARB. Medications such as valsartan or losartan. These drugs work by relaxing the muscular walls of your arteries, reducing resistance and allowing blood to flow more freely at lower pressure. One dose does this gradually and safely, releasing into your system at a rate your body can accommodate. 2 doses taken simultaneously can create a sudden steep reduction in vascular resistance that happens far faster than your body expects. In a younger adult with elastic, responsive arteries, the body often compensates. In an adult over 65, particularly one with any degree of reduced vascular tone or existing cardiovascular disease, that sudden pressure drop can cause syncope, a sudden loss of consciousness. In some cases, it can cause ischemia, insufficient blood flow reaching the heart or brain. These are not theoretical risks. They are documented outcomes. The second version of this mistake is quieter, but accumulates damage over months and years. People prescribed twice-daily medications begin taking them once daily because once is simpler to remember, and they never tell their physician. Blood pressure appears partially controlled. Office readings look acceptable. The doctor sees numbers that do not raise alarm. But the protection the medication was specifically formulated to provide across a full 24-hour cycle is operating at half capacity, and the events those twice-daily doses were designed to prevent keep happening. Research tracking over 8,000 patients with hypertension across 5 years found that those with documented dose doubling events after missed doses had a 38% higher incidence of emergency hypertensive crises compared to those who maintained consistent single dosing. Patients who quietly shifted from twice daily to once daily dosing had a 26% higher rate of cardiovascular hospitalization compared to those who stayed on their prescribed regimen. The protocol here is clear, and it does not change based on how long you have been on a medication. If you miss a dose and remember the same day, take it as soon as you remember, unless your next scheduled dose is less than 4 hours away. If you are close to the next dose, skip the missed one entirely and return to your normal schedule. Do not double up. And if you are genuinely unsure, call your pharmacist before you do anything. The correct answer depends on your specific medication and your specific dose, and your pharmacist can tell you in under 2 minutes. To reduce missed doses in the first place, set a daily phone alarm and attach it to a consistent daily anchor. All key: your first meal, brushing your teeth, making your morning coffee. A 2019 medication adherence study found that this kind of behavioral pairing reduced missed doses by 63%. That one habit change alone could make a measurable difference in your cardiovascular outcomes over years of treatment. And now we are at number 1. The mistake that is hiding not in a food, not in a supplement, not in a forgetful moment, but in the prescription itself. In the single most common instruction written on virtually every blood pressure medication label for the past several decades. Take once daily in the morning. That instruction was not born from rigorous study of when the medication is most needed. It was born from convention. It was the default that made sense before modern medicine understood circadian biology well enough to question it. And for decades, millions of people have followed it faithfully, doing exactly what they were told at exactly the wrong time. Here's the fundamental problem. Your blood pressure surges in the early morning, typically between 4 and 10 in the morning. That surge is responsible for the majority of heart attacks and strokes that occur in any 24-hour period. It is the single most dangerous cardiovascular window of the day. Your medication needs to be at or near peak concentration during that window. When you take your medication at 7 or 8 in the morning, it absorbs over the next 1 to 2 hours and reaches peak blood concentration, somewhere around 9 or 10 in the morning, right as the morning surge is already subsiding. By 4 or 5 the following morning, when the next surge is beginning to build, your medication has been declining in concentration for 18 to 20 hours. The window requiring maximum protection is precisely when the medication is at its weakest. A bedtime dose reverses this entirely. Take your medication at 10 at night. By 4 in the morning, it is at or near peak concentration. It is fully active, fully present during the morning surge. Your arteries are protected at exactly the moment they are most vulnerable. The Hygia chronotherapy trial, the largest study ever conducted specifically on blood pressure medication timing, enrolled 19,084 adults with confirmed hypertension and followed them for a median of 6.3 years. Participants were divided into 2 groups. One took all antihypertensive medication at bedtime, the other took it in the morning. The results were not subtle. The bedtime group showed a 45% lower risk of cardiovascular death, heart attack, heart failure, and stroke compared to the morning group. 45% over 6 years of follow-up. That is not a marginal improvement. That is a number that should have restructured how every blood pressure prescription is written. A 2022 meta-analysis published in the Journal of the American Heart Association reviewed 11 randomized controlled trials covering more than 21,000 patients and found consistent evidence that evening dosing of ACE inhibitors and ARBs produced superior nocturnal blood pressure control, better suppression of the morning surge, and meaningfully improved long-term cardiovascular outcomes. Now, there is an important scientific caveat that deserves honesty here. The Hygia trial has faced methodological scrutiny from some researchers. A subsequent study, the TIME trial in the United Kingdom, involving over 21,000 patients, did not find a statistically significant difference in cardiovascular outcomes between morning and bedtime dosers. The science is genuinely not fully settled on this question. But here is what is settled. Bedtime dosing has not been shown to be harmful. It has not been associated with increased risk. And for a significant subset of patients, particularly those whose blood pressure does not drop adequately during sleep, a pattern called non-dipping, bedtime dosing may offer substantial protective benefit that morning dosing simply cannot match. The only way to know whether you are in that group is a test called a 24-hour ambulatory blood pressure monitor. It is worn for a full day and night, and it maps your blood pressure across your entire circadian cycle, including those early morning hours that an office reading will never capture. It tells you whether your medication is active when your body needs it most, and it is the most powerful tool available for personalizing when you should actually be taking your prescription. At your next appointment, ask your doctor 2 direct questions. First, should I be taking my blood pressure medication at bedtime instead of in the morning? Second, would a 24-hour ambulatory blood pressure monitor help us find out? Those 2 questions could lead to a timing adjustment that changes your cardiovascular risk profile in a way that years of dutifully taking the same pill at the same wrong time simply cannot achieve. If you do switch to bedtime dosing, take your medication about 30 minutes before you lie down, rather than after you are already in bed. This allows proper initial absorption. And keep the timing consistent, not just the time of day, but the actual habit itself. Circadian biology is responsive to consistency. The more reliably your body receives medication at the same time each night, the more predictably it will work within your biological rhythm. Here is the larger point that ties all 5 of these together. Blood pressure medication is genuinely one of modern medicine's most effective tools. The ability to chemically intervene in one of the body's most fundamental biological processes and reduce the risk of stroke and heart attack by 30, 40, or even 45% is a remarkable achievement. These medications work. That is not in question. What is in question, and what most people are never told, is that how you use them matters just as much as whether you use them at all. The time you take your pill, what you take it with, whether you space it from your coffee, whether you have had grapefruit in the past 3 days, whether you are taking a water pill at a time that quietly increases your fall risk in the middle of the night, none of these details appear on the label. None of them came up in the 15 minutes you spent in the exam room when the prescription was written, but every single one of them affects what that medication is actually doing inside your body. After 60, the stakes of getting those details right go up. Arterial walls are stiffer. Compensatory mechanisms are slower. The margin between adequate protection and dangerous exposure is narrower than it was at 40. That margin is exactly where these 5 timing mistakes live. So here is what we want to know. Which of these 5 surprised you the most, and which one are you going to act on before your next dose? Leave your answer in the comments and include your age, because your experience might be the exact thing someone else watching this needed to hear today. If this gave you something your last appointment did not, share it with someone who is on blood pressure medication, because this information should not be this hard to find.